We are back in the Dermcast Live studios in Nashville, Tennessee. It's Rob Casquejo, and today I have a distinguished and honored colleague, Michael Overcash, who's going to talk to us about medical missions and some interesting cases that he's seen in his travels. Welcome today, Michael.
Thank you, Rob. Thanks for having me here.
Great. It's an honor to have you in the studios, and you and I have something in common. I myself have been on 5 international medical missions, so I'm always interested to hear about other folks' experience in these situations. But before we get going, why don't you take a second to talk about, tell us about yourself as a clinician.
So I'm a dermatology PA for over 20 years now in Charleston, South Carolina. I got into the PA profession because I went on a mission trip and saw firsthand what was possible. Never heard of a PA before that, but now I realize that we are impacting the world like I'd never thought possible before.
That's amazing. So, I know you've done a lot of this. So tell us briefly about the backdrop of the missions you go on, organizations you work with, that kind of thing.
So since the 90s, I've worked in 50 countries now, and I work mostly with nonprofits, some church organizations, at some points with governments, like with Nicaragua. It always looks different. But basically what we do is we send short-term teams and professionals to go support long-term projects in places where they need dermatology, where there are almost no dermatologists at all.
Got it. So when you join these the missions, are you attached to certain groups? Do you sort of freelance and just go from agency to agency, organization to organization? Are you going through other community-based things like your church or local community groups?
Yeah, so long ago I used to freelance, and that's pretty rough. I wouldn't do that anymore. I highly recommend going with an established group. I have a local church called Seacoast, and Seacoast has been doing missions for probably 30 years now. A lot of the trips I do are with Seacoast, with partners overseas. Also, I work with a nonprofit called One World Health. My friends and I founded that in 2008. We actually build permanent clinics overseas and then staff them with locals. Our short-term teams are then prepared from anybody in the country that wants to go, and then sent about 20 times a year to provide specialty care to those clinic sites.
Well, that sounds amazing. So I didn't know you were involved at that level. So you actually have done international outreach and established brick and mortar type situations. And so when your teams are not working there, are there local clinicians working in those clinics while
Right.
you're not there?
Yeah, and so the clinics, we have over 24 clinics now that run year round, all the time. During COVID, we did some telehealth, but none of the clinics closed. We have some labs, we have operating rooms, we have some labor delivery units, mostly in Africa, Southeast Asia, and Latin America. But they're staffed by locals. This is really important because Americans want too much money. That's not sustainable. Locals, we pay local rates, maybe a little better, but something that doesn't inflate the economy and something that is sustainable long term. So the clinics can actually pay for themselves once they're started.
Wow, that's amazing. So I had no idea. When we get off camera, I have to ask you a little bit more about that. But that's amazing. And what's the name of the organization? You said it again.
So the biggest one is One World Health, and that's mostly Uganda, Nicaragua, Honduras. And then I also work with a group called Vets with a Mission, not veterinarians, but veterans. And that's in Vietnam, Laos, and Cambodia, and then Seacoast Church.
Got it. That's amazing. So real quickly, a lot of times for those who are watching and think to themselves, I really would like to try my hand at this. But the common thing that I hear from folks is, I've been practicing mainly dermatology. I'm not sure how my skill will apply to scenarios like this. Can you tell us briefly about how you work as a dermatology clinician, a dermatology PA in these situations?
Let me tell you, that is such an important question because I take all these teams of people that are students or non-medical or inexperienced people. They are gung-ho, ready to go. People with no money and no experience. They don't hold back. They're ready. Okay, I take kids. But it's the doctors and the PAs that say, oh, I don't know enough. I'm worried. I don't know. I'm not an expert on international medicine. I don't have enough money. but the truth is they do have the ability. And even though we're all specialists in dermatology or something else, we have such a basic level of care we provide on these trips. If you have diabetes, you get metformin, okay? Maybe a glipizide, but it's really super basic. The tests we order, things we prescribe are simple. And you always work with a team. There's always local doctors with you. So you always have a room full of people. And listen, they're going to be grabbing you constantly because all day long, there's going to be kids and adults and people with skin lesions and rashes. And you know how it is in dermatology. Nobody knows what anything is. Guess what? You do. You know what over 90% of it is. Now, if they don't have you there, they're just going to guess. So it's a huge, powerful contribution to have a derm PA.
Right, that's such a good point, because a lot of times skin complaints, at least my experience had been that sometimes the skin complaints are almost sidebars sometimes to them coming in, but it's something that's noticeable. And so you end up being used in scenarios where the chief complaint may not even been skin based. And the other thing is the team approach. You said there's always, if you have something in front of you, you're not sure what's going on, there's always a team of people around, whether they're local or have traveled with you, that are willing to help. And that's the thing. I always say to people, you don't get a lot of jerks on medical missions, right? Just by nature,
Right,
they're going to be very, very helpful, very willing, very approachable people. So it's an important part, the culture of missions in general.
We all learn so much. Like I learned so much from all the other specialists. About 10 years ago, I started doing dental extractions out of necessity, and we had a great dentist to teach me. Likewise, you'll be teaching dermatology to all your peers. In America, it doesn't work this way. If you want to refer someone to endocrine, it's going to be a while, right? Rheumatology, it's going to be a while, and you're not going to be there when that patient sees them. But this is different. You're all in maybe a big church or school. Well, you just take this person by hand and walk them over and say, hey, what is this? Hey, this person has this. Will you look at their joints? Will you listen to their heartbeat and tell me what you hear? And you get an instant consult. And our patients on missions might see 3, 4, 5 specialists in one day. They get physical therapy. They might have a professional counselor. They might see derm, and then they see rheumatology, and then they see the pharmacist. So in some ways it's primitive. In some ways it's a lot better than what we have here.
Yes, and I think I always tell folks too, you've alluded to this, but when you're working in a situation, even if you're in a specialty like dermatology, you'll be surprised what you remember from your training. And when you look at something and maybe there's a problem outside of dermatology, you'd be surprised what you can actually bring out of your recall in terms of helping someone. That's fantastic. Well, thanks for sharing those experiences. So let's move on to the really cool part of this. And you've brought some cases that we're going to look at that you've seen in the course of your work overseas. So why don't we get going with that, and we can have you start with one of your cases.
Okay, let's do it. People always ask, what's the craziest thing you've ever seen on a mission trip? And it's so many things. I can just pick from this year, and that's what I did, and I have some current cases for you.
Okay, great. So let's take, I'm gonna just follow along in the order that I'm taking a look at the photographs that you've got here now. So why don't you start with your first patient?
Okay, so I can't see the photographs, but who is this?
Oh, okay. So this is this is your first case, your mystery case number 1. Male patient arrived hopping around using a cane.
Yes. Yeah, so this guy's in Uganda, and he has this large sort of purplish blue mass that's right there on his heel. And so he can't walk on it. And it's grown slowly for years. And, in that part of Kenya, we saw quite a few of these. It's really quite purple, almost like an angioma, but not that red, more dusky, more dull. So my question is, what is this thing? What are you going to do about it? You're in the poorest part of Kenya. You have no lab anywhere. You're probably never going to see this guy ever again. So that's my question.
Okay, so outside of a diagnosis, you just said that this is common, so that's my biggest clue. So I'm going to start thinking of not something that's more immune-driven purely. I'm going to think of something that's probably potentially more infectious. So if I had the option, I'd want to biopsy this, of course. So that's something important people always ask about dermatology in these settings. So can you talk about that for a minute, about the potential or the need to biopsy?
Yeah, so we do quite a few biopsies on every trip. And I will say, if you're planning on going on a trip as a Durham PA, ask your host organization, will I have the ability to do biopsies? Because if they say no, you're handcuffing yourself. Okay. We as Durham PAs, we need to do biopsies. So you should be able to. There is international law that makes sure, that guarantees that you can bring back tissue specimens and formalin to the United States. I have those documents in my PowerPoint actually. So we do often do biopsies. In that case, you have to get a contact, with the person, because otherwise, how do you get results back to them? Several times we've done breast biopsies and had found breast cancer, and then come back and say, okay, listen, we can cure this breast cancer, and done exactly that. Other cancers as well. But in this case, the treatment's empiric. So this one is a Kaposi sarcoma, and the foot location is classic. And you see so many people in Kenya with Kaposi's on the foot that this is something you just remove it, bandage up, and keep going. So a little different in this case. I did not even take a tissue specimen back. The color, the location, the lesion presentation is so obvious. It's almost like if you look at a nodular BCC with your dermatoscope and you see telangiectasias, some blue dots, maybe some spoke wheel leaf figures, you already know what it is. And now here you're going to send it for PAT. But on a mission trip, you're probably just going to treat that empirically, maybe get PAT when you get home to confirm it.
That's fantastic. So you were able to identify this clinically based on your experience. So I was sort of right here, because as you know, some of the causes of Kaposi's, basically the viral influences and so forth. So is it the case with this tumor as well?
Yeah.
Is that what you would typically see?
That's really important to mention, because it is not. So in the US, if you see Kaposi's, you're almost certainly going to think, okay, this person probably is HIV positive, probably has full-blown AIDS at this point. But that is not the case in Africa. In Africa, Kaposi's, yes, it's caused by human herpes virus 8, but it is endemic. It is not caused by HIV, and it's poorly understood. We don't know why, but people just have Kaposi's even though they're healthy and don't have HIV.
Okay, that's very interesting. Okay, so how did you treat this gentleman?
So just pretty easy, just local anesthesia at the base of the lesion, and then just carefully dissect across the heel to give it a natural contour using cautery. I always bring a Bovie with me. If there's no electricity, I just use the battery-powered cautery devices. But if there's power, that's the one thing I gotta have that's electric, is a Bovie. And then just wound care. It's pretty simple.
Okay, that's amazing. So do you have follow-up on this gentleman?
So I do, and you can see a picture immediately after the procedure, and then some other Kaposi's cases. But he actually is near a school called Christ Gift Academy, and has follow-up with the teachers and the missionaries there. And they can send pictures to us, and they do.
That's fantastic. Well, great. Okay, that's an awesome case. All right, let's move on to anything else you want to spin on that? I mean, those are interesting aspects of a disease that we know about, but very interesting aspects in terms of international medicine. So let's move on to your next case. This is your 40-year-old male, generally healthy and HIV negative, with a 5-year history of progressive leathery covering of the skin.
This is the most fascinating case in this whole deck. This man, just like when Spider-Man had Venom take him over and put that black Spidey suit on top of his body, this guy has this thing that's crawling over his body and covering him. And it's even like covering his digits and squeezing them and pinching them. And so waist down, his hands, his arms, it's now pinching off his fingers, and his fingers are falling off, which is actually something we see in Africa not infrequently.
Okay. So just from your description and from looking at the pictures, from my Western eyes, I'm going to think of something like maybe, old school syphilis. That's the first thing that comes to mind for me. The lesions that you're describing, the constrictive, perhaps potentially gummatous type lesions, but that's the first thing that comes to mind to me.
It's hard, right?
Right. So
I didn't know what this was. Full disclosure, I had no idea what was wrong with this guy. And did a biopsy, okay, and brought that back. He actually has this thing called camisa syndrome. It's camisa, like a shirt in Spanish, t-shirt. I had never heard of Camisa syndrome. It's a subtype of Vohwinkel syndrome. These people have a mutation in the loricrin gene, and it causes them to have hyperkeratosis of the palms and soles. But it also progresses to cover their digits and wrap around their digits and pinch them off. In this case, it does not include hearing loss. That's why it's called Camisa, not Vohwinkel. And the amputation of fingers is called Einem. And that happens naturally in Africa without any known cause. It's idiopathic. But his would be called technically pseudo-Einem because has a known cause, which is his Camisa syndrome. The treatment for it is oral retinoids. Now, we're not going to do isotretinoin or acitretin. What we do is high-dose vitamin A. A lot of countries you can buy vitamin A 200,000 IU. It's probably not safe in pregnancy. I think at high enough doses, you could get hypervitaminosis A, but thankfully that's not very common. And you can usually monitor it by side effects, actually, without too much blood work.
Okay, that's interesting. So it's innate. It sounds like it's a genetic situation. And what is the demographic of this where you saw it? Is it something even rare there, or is it?
It is rare. It's rare everywhere, but India and Africa are the most reported. Latin America also, but it can occur everywhere. It's just more common in developing nations, which we don't know why. And then actual Einem, where your fingers fall off spontaneously, that is very much an African thing. Completely don't know why it happens. It's linked to poverty, but nobody knows.
Yeah, that's really interesting as well. So,
So
and
many
then
times.
you treated this gentleman with high dose vitamin A. It sounds like, and you have some outcome from his case.
Yes, so we also amputated his pinky. The reason he came in is because this finger was in so much pain, just throbbing, aching nonstop, can't sleep at night pain. So there's a picture, there's a video on my YouTube channel of the student amputating this digit, which is really quite easy to do. That's what he wanted done. It was just the amputation. And then we started him on vitamin A. So we have some doctors there that are able to follow up with him and give us reports on his condition as well.
That's great. So we'll make sure to get that link from you too, and we'll put it up in the video. Okay, fantastic. So it sounds like he did okay. And so the recovery, it looks like this is a scarring condition. So even after the vitamin A, there's still scar, I'd imagine, in the lesions, but the lesions don't progress.
You really can stop loss of other fingers. So oral retinoids can save the rest of his digits actually and prevent, because otherwise one by one, they're going to go. He'll lose them all.
Well, that makes sense. Great. Okay, so it sounds like there's at least a good endpoint with treatment with this. Okay, fantastic. All right, let's move on to the next case. This is your 44-year-old male, generally healthy. His nose is growing longer despite not telling lies.
Yeah. I thought that was great how you threw that in there. So if you can see the picture, his nose is quite long. And he's like, I'm not telling lies. I think everyone's heard the Pinocchio story. And it's super nice guy, very friendly, but he's like, this is really affecting me socially. His nose was quite long. You could see it transilluminated brightly, like a Christmas tree light with a pin light. So my question is, what do you do? What do you do? Which is always the question every day on a mission trip. What do you do? Because this is your one chance.
I'd say, okay, so seeing this and looking at your physical exam findings, you mentioned specifically that it transilluminates. Mm-hmm. So I'm thinking something cystic was really what would come to mind for me. So I think I'm trying to think of what I would do in the situations I'm in normally, in these international missions, is I might, if I know the resources, I would probably do something, I would try to aspirate it, number one, to see if it's a solid tumor. If I draw fluid, I would try to keep it for cytology. Then I would try to do something maybe exploratory, maybe just do a just do some, an excisional exploration just to see if I can expose something that looks cystic and that might be actually surgically treatable.
Mm-hmm. So we'll say you did that and you got clear fluid, looks like water. And then, there's this loose skin that covered that water-filled cyst. And if you reflect those flaps back, you really can't see a sac at all. So I did that. That's the answer I chose as well. So I reflected the skin back and I took a little punch biopsy of the tissue underneath to see if we could capture any useful cytology, right? We did later prove this was a hydrocystoma. So we all see hydrocystomas here, right? We see them there all the time. But this is just an ecrine hydrocystoma. That's it. So what I did is just drew an ellipse on his nose and then took out the excess skin and did a closure, which you could see in the slideshow, and just did a few sutures right there midline. He was very happy. He's got a nice looking nose, actually.
He does. Look at that.
Yeah.
He's just got a nice shape and everything. And
Yeah.
wow. Okay. So another a pretty simple solution.
Very
And
simple.
this guy, I imagine, like you said, probably pretty happy. So good
Yeah.
outcome. Okay, let's move on to your last case, your fourth case here, and this is looks like this was in Uganda in a rural farming community, and verrucous changes to both feet.
It's pretty striking. I will point out several other people in the community had similar presentations of the feet, swelling of the foot, swelling of the ankle, sometimes wart-like projection, sometimes bumpy sort of nodules on the toes, feet, and ankles. Any thoughts?
Well, I would say if there's, do they work bare feet typically?
Yes. Walking barefoot
Okay.
all the time, whole life.
So, okay, thinking broadly and not having a compendium of experience in this sector of the world, I'd start thinking of something infectious again. And I know that mycobacteria can have verrucous appearances when they are cutaneous. So I would lean towards that. And again, I want to verify with a biopsy.
So yeah, you got to think about mycobacteria. Actually, leprosy. In that same community, we have people with leprosy, and they show foot changes, loss of toes, for example. Also, infectious things like filariasis. So filarial worms infect lymphatics, block lymphatic drainage, and called elephantiasis. That's something we also see in Kenya and Uganda. But this one is actually this thing called photo.
I would have thought of that.
Yeah.
But you didn't give it as a choice.
Okay. Yeah. I thought it was a bit unfair because you can't tell by looking at it for sure. And in fact, what we do is we cover both. So the diagnosis is podoconiosis. And podoconiosis is just caused by walking barefoot. It's caused by not having shoes. So walking barefoot, especially if the soil has powder, this community has a lot of volcanic ash in the soil, and it gets into the skin, and then it blocks the small lymphatics. So that causes these bulbous areas where the lymphatics cannot drain properly. Now, it looks a lot like filariasis. So what we do is we cover them for both. So we treat them with albendazole in case they have a parasitic infection. We usually give one dose to treat everybody every 6 months, regardless, right? Because parasites are so common. But then you also use compression and give them shoes for podoconiosis. And it's remarkable how much smaller their leg can get if they will wear the compression, just an ACE wrap.
That's great. Okay, so now these lesions, does the treatment free up the lymphatics so you have recovery, or is this, I imagine there's some scarring, this is a scarring condition as well?
Yeah, it's probably not going to free up the lymphatics. They're filled with debris and ash and dust and dirt. So, you can stop it from getting worse. You can keep them walking, but you're probably not going to reverse it much at all. The swelling, yes, but the lymphatic damage, no. It's scarred.
Okay. And so what are the typical outcomes then following treatment for these folks?
Mm-hmm. So if they'll wear the shoes, they'll do great. You'll see them next year. They're still walking. It's a little better. Their ankles are definitely smaller. They move better. But it's a long-term chronic treatment. Education's big too. So we bring suitcases of shoes down sometimes, and you also have to convince people to wear the shoes because sometimes they just don't like it. Like tell Pele to play soccer with shoes on. He played barefoot his whole childhood. He was terrible when they put shoes on, right? It's an adjustment. But if they can see the value in protecting their feet and their future walking and legs and ankles, they'll wear them.
Fantastic. So, wow, what I think, it's very humbling to see cases like this, the severity, but then also encouraging to know that there are some good outcomes, even for these things that we see in very limited situations. And I
Right.
think that's really a good summary of what happens in medical missionary work.
So, Rob, you're right. I got to tell you this. In Swaziland, whenever, we're the foreigners, we're drinking bottled water. Whenever one of us finishes a bottle of water, the kids will surround you and ask, please, please, may I have that bottle? And they eagerly want that bottle that had water in it. What they do is they smash them flat and then they tie reeds through it and make a flip flop out of it. And so they walk with the bottom of the shoe is actually your flattened plastic bottle. So you'll see these kids walking around on plastic bottle shoes they made themselves. So that puts it in perspective for me. When my kids are asking for something, I'm thinking there's kids walking on plastic bottles, right? That would do anything just to get one more plastic bottle for the one that's broken.
It definitely, perspective is the one word that I would think I would use if I had to summarize my experiences in missionary work is perspective. It really
Right.
does change how you see things. Well, what an honorable way to have started your career and to propagate your career. This is amazing, and I'm gonna get with you. Maybe I'll be able to jump on one of these things with you. I'd love that experience, and you and your crew can show me a few things.
We'd love to have you any trip.
All right, awesome. So I'll plug your organization one more time, and anything else that you want, if people want to reach out to you or communicate with you about your experiences in your organization.
Yeah, so I would say I recommend One World Health. The Seacoast Church trips, they fill up over 6 months in advance. They're all over full. But One World Health has more trips, more per year. They don't have a faith-based requirement. Anyone can go from anywhere. So it doesn't matter if you live in Seattle, there's probably 13, 15 states on some of our teams. And it's just oneworldhealth.com.
Fantastic. Well, thanks for taking time, Michael, to visit us at Dermcast Live. It was your experiences. I'm sure they'll be received well, and I'm hoping that you may have even motivated some of our colleagues to take a look at these things and bring their skills out to the international medical world. Thanks again, Michael, for hanging out with us, and I hope to have you back sometime in the studio.
I appreciate it, Rob. Thank you.
Thank you. And reporting from Nashville, Tennessee, it's Rob Casquejo for Dermcast Live.